So in Japan, both haplotransplant and cord blood transplant are increasingly performed. Number of cord blood transplant is 1,200 per year, and haplo-PBSCT 600. So number of cord blood transplant is greater than those of unrelated bone marrow transplant and PBSCT. And all cord blood transplant exclusively single unit cord blood transplant. We never use double unit cord blood, double cord transplant. With this background, so we conducted the first matched pair analysis comparing PTCY haplo with cord blood transplant for leukemia and MDS. So result, although incidence of grade 2 to 4 acute GvHD was slightly less in the PTCY group, grade 3 to 4 acute GvHD and chronic GvHD was comparable between the groups. However, non-relapse mortality was significantly higher in cord blood transplant, whereas disease relapse was significantly higher in haplo-PBSCT. As a result, overall survival was better in haplotransplant in patients with low and intermediate risk. On the other hand, overall survival was comparable in patients with high risk disease. And also, rates of immunosuppressant are remarkably 85% at 2 years after PTCY haplo, and also 70% after single unit cord blood transplant. Both are much higher compared to standard HLA matched bone marrow transplant and PBSCT. This results in improved quality of life and quick return to school or work. So both are rapidly available donor source and thus valuable alternative to HLA matched stem cell transplant. In Japan, in the absence of HLA matched donors, and when patients cannot wait unrelated donor coordination, we search cord blood donors and haplo donors simultaneously. After considering CD34 cell numbers in cord blood and availability of haplo donors, better one is selected. In addition, haplo would be preferable in low risk or in higher intermediate risk patient. In high risk patient, both produce similar transplant outcomes, so both are available. So that's it. Thank you very much for your attention.